treatments determined by, when we think that someone is an eligible candidate and we can help them. The biggest treatment for peritoneal surface malignancies right now and most effective is the surgery I do, which is called CRS HIPEC, or cytoreductive surgery and hyperthermic intraperitoneal chemotherapy. The best way to think about this is kind of going back to my metaphor, is the CRS addresses the macroscopic disease, the disease I can see with my eyes, the weeds growing in the garden, whereas HIPEC addresses the microscopic disease, disease that is kind of underneath the surface, disease I can't see, seeds that are kind of growing under the soil there. This is a combined surgery. This all happens at once. I do the CRS first, and then when that's been completed, I've removed all the disease that I can see. We then pump the hot chemotherapy in the abdomen afterwards. These procedures can be very long. They're very high risk. They involve resection of multiple organs, such as the omentum, the gallbladder, the appendix, some of the colon, the spleen. They can take me 8 hours, 10 hours, 12 hours, 14 hours. It just depends on how much disease they are and what kind of pathology we're dealing with. They also have a big recovery after you get out of the hospital. It takes patients multiple weeks until they feel back to normal. And it comes with implications sometimes. It can come with infertility if I remove ovaries, or creation of a permanent ostomy. Quite simply, CRS HIPEC is not a surgery we take lightly. It is a very big undertaking. It is one of the largest surgeries someone can undergo. And that's why we are very selective about who we think is going to benefit from this, because we want the benefits to outweigh the risks. But that being said, for the people that we can help, it does very much work in terms of extending survival. And I'll get into that data in a minute.